What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my EMS EMT playlist. In previous videos, we talked about how to examine a patient in an emergency situation. We talked about the vital signs, including the heart rate, the respiratory rate, the pulse, and the temperature. We talked about how to examine the head and neck, the chest, the abdomen, the pelvis, the extremities, the skin, the pupils, and much more. We also talked about the Cushing reflex, pulse oximetry, and capillary refill time. Today, let's dig deep into the topic of respiratory emergencies and how to manage them like a pro. Click the like button, click the subscribe button, and let's get started. But before we get started, remember that emergency is all about ABC. Airway, breathing, circulation. This is my EMS playlist. Please watch these videos in order for maximum understanding and retention. Not to be confused with your patient's urinary retention. Once you arrive at the scene, you assess the scene. Is it safe or not? Then, is it a trauma condition or a medical case? Then, don't forget the ABCs. Understand what caused the injury and what the nature of the illness is. Then, make sure you know the patient's age, sex, appearance, pregnant or not. Introduce yourself, ask the patient about his or her name. Is your patient conscious? If yes, ABCs. And they are probably okay if the patient is conscious and able to talk to you in complete sentences. But if not, if the patient is not conscious or not responsive, ABCs big time. The A stands for airway, B for breathing, C for circulation. If the airway is closed, open it. If there is apnea, ventilate it. If the pulse is lost, start CPR or cardiopulmonary resuscitation. Cardiopulmonary because it's the job of the heart and the lungs to supply all your tissues with oxygenated blood. The vital signs are pulse, blood pressure, respiratory rate, and temperature. To understand the difference between the word pulse and heart rate, please refer to the previous videos, especially my video on the vital signs. You can use the sample method. The S, signs and symptoms. A, is the patient allergic to anything? M, is the patient taking any medications? P, pertinent history or present history. L, is last oral intake. What was the intake and when was the intake? And A is the events that happened before the episode. One of the most important decisions that you have to make is, depending on the severity, should I wait and treat or should I grab and go? If it's something minor like a scratch, we can wait and treat on the spot. But if it's a heart attack or a stroke, we gotta load and go. The following are red flags that necessitate that you load and go to the hospital, including a patient who's unresponsive, a patient who is responsive but cannot follow commands, complicated childbirth, severe pain, severe bleeding, shortness of breath, and shock. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. If you want me to personally tutor you, reach out to me on my website. The levels of consciousness were discussed before. Remember, you start conscious and then you deteriorate downwards like this. Confused, delirious, somnolent, obtunded, stuporous, and comatose. We need to get the phrase #obtunded trending. What are we going to talk about today? Airway versus breathing versus ventilation versus oxygenation, because these words are not synonymous. We'll talk briefly about the anatomy of the lung. We'll talk about signs of respiratory distress, respiratory failure, respiratory examination, abnormal breath sounds, and the emergency situation of status asthmaticus. In emergency medicine, you remember ABC, airway, breathing, circulation. For the pros, add D and T. D, drugs, including what antidote I should give if an antidote is available, and the T is temperature. Now, what's the difference between airway, breathing, ventilation, and oxygenation? Let's find out. First, the airway. Airway is just the anatomy. Look at this. You can breathe through your nose, which is preferred, or through your mouth. Regardless, the air is gonna end here in the pharynx. The pharynx is made of three parts: nasopharynx behind the nose, oropharynx behind the oral cavity or the mouth, and laryngopharynx behind the larynx. And then the air is gonna pass into the trachea or the windpipe. So you go nose or mouth, and then pharynx, and then larynx, and then trachea. This is the trachea in the middle of the neck. In front of the trachea, there is the famous gland known as the thyroid gland. This is the larynx, this is the trachea or trachea, and then the trachea will divide into right main stem bronchus and left main stem bronchus. Notice that the right main stem bronchus is more vertical, like this, but the left main stem bronchus is more horizontal, like this. Oh, this is right, this is left. More vertical, more horizontal. Why should I care? Because let's say that I had an aspiration. Oh, something went to the wrong pipe, and then it's gonna go to the trachea, Okay, do you think the odds are that this thing will land on the right side or will land on the left side? The answer is on the right side. Why? Because the right main stem bronchus is more vertical, so it's easier for the foreign object or the bacterium to go to the right than to go to the left. This is a sharp turn, so it's harder to do. Remember my 10 commandments of respiratory management. Number 1, if the patient is conscious and speaking in a normal tone of voice, the airway is open, which is normal. Another commandment tells you that if the patient's breathing is noisy or gurgly, thou shalt secure the airway now. If you want to see more videos like this in the future, please drop a heart emoji in the comments. So airway is just the anatomy. It's your nose, your nasopharynx, your larynx, your trachea, and your bronchi. What is breathing then? No, breathing is different. Breathing is physiology. So if airway is the anatomy, then breathing is the physiology. What do you mean by physiology? I mean gas exchange. Oxygen in, carbon dioxide out. Push the oxygen to the blood and remove the carbon dioxide from the blood. Inhalation versus exhalation. Inspiration versus expiration. A third concept is ventilation. What is ventilation? Ventilation is how fast times how strong or how deep you breathe. How many times do you breathe per minute is called the respiratory rate. This is how fast. This is the frequency of breathing. Times the tidal volume, which is the depth, how deep you breathe. Multiply how fast by how deep, you get ventilation. There are two types of ventilation. There is pulmonary ventilation and alveolar ventilation. What's the difference between the two? If you know the answer to this question, please comment below. The answer to this question is to be found in my pulmonology playlist or in my physiology playlist. Bringing air to the alveolus is called ventilation. How fast times how deep. Bringing blood and pumping it towards the lung is called perfusion. Between the alveolus and the blood, there is gas exchange via diffusion through these tissues. Again, ventilation is how fast times how deep. Respiratory rate multiplied by the tidal volume. Let's say that your respiratory rate is 12 breaths per minute. And let's say that the normal tidal volume is about 500 mLs. If you want to measure the pulmonary ventilation or the minute ventilation, you multiply this by this. And what do you get? You get 6,000. 6,000 what? mLs per minute. What if I want to convert this to liters? You divide by 1,000. So it's going to be 6 liters per minute, and this is normal. Pulmonary ventilation. Please note that the value of the tidal volume in the normal population differs. It's different between males and females, and it differs by age. Young, healthy people usually have higher tidal volume than old people, even in normal circumstances. So what is airway? Airway is the anatomy. What is breathing? Breathing is the physiology. Hashtag gas exchange. What is ventilation? It's bringing air to the alveoli, which depends on how fast times how deep. But what is oxygenation then? Oxygenation is to push the oxygen into the blood and then onto the hemoglobin. When the oxygen is freely floating in the arterial blood, we call it the partial pressure of arterial oxygen. Once that oxygen jumps onto the hemoglobin and the hemoglobin becomes saturated with oxygen, we call this the saturated arterial oxygen. Who is being saturated with whom? The hemoglobin is being saturated with oxygen. What is the hemoglobin? It's a humongous protein on your red blood cell that helps you carry oxygen and or carbon dioxide. let's dig deeper into the topic of oxygenation. You breathe air from the atmosphere. The atmosphere has its own atmospheric pressure, which is about 760 millimeters of mercury. The atmospheric air is a mixture of all kinds of gases, including nitrogen, oxygen, carbon dioxide, etc. The oxygen alone constitutes about 21% of the atmospheric air. So we can multiply the 760 by 21% or 0.21 to get about 160 millimeters of mercury. This is called PiO2. PiO2 is the pressure of inspired oxygen, and FiO2 stands for fraction of inspired oxygen. The fraction is 21%. This PiO2 is coming to my lungs. Once it reaches the alveoli, it changes its name by a verbal sleight of hand into PaO2, which is the partial pressure of alveolar oxygen. Then the oxygen will leave the lung and go to the blood. When the oxygen is freely floating in the blood, it's called arterial oxygen. So this is the partial pressure of arterial oxygen. Then the oxygen will jump onto the hemoglobin. Now the hemoglobin becomes saturated with oxygen, and we call this SaO2. When we measure oxygen saturation, or O2 sat, or percent saturation, or SaO2, we are measuring this 99%. 99% is normal. Less than 90% is a disaster. Then, of course, the hemoglobin will give oxygen to the cells or to the tissue, and then there will be little oxygen left in the venous blood because the cell will take the oxygen from the arterial side and then dump carbon dioxide onto the venous side. So, the venous side has carbon dioxide, and it has some oxygen that is less than the oxygen in the arterial blood. How much oxygen is in the venous blood, or the partial pressure of venous oxygen? It's about 40 millimeters of mercury. But in the arterial blood, it was much more, 100 millimeters of mercury. So now you know what hemoglobin oxygen saturation means. It means how much is your hemoglobin saturated with oxygen. The normal is about 98 or 99%, and this has many names. You can call it pulse oximetry result, oxygen saturation, hemoglobin oxygen saturation, or SaO2, or even percent saturation. We are done with the first point. Next, anatomy of the lung. Quick review. The respiratory system. Remember, mouth or nose, and then the pharynx, and then the larynx, and then the trachea. Then we have right main stem bronchus and left main stem bronchus. The right main stem bronchus will enter into the right lung, whereas the left main stem bronchus enters into the left lung. The right lung has 3 lobes, upper lobe, middle lobe, and lower lobe. The lower lobe is going to continue on the back of the lung. As for the left lung, it only has 2 lobes, upper and lower lobes. So in total, both of your lungs have how many lobes? 1, 2, 3, 4, 5. 5 lobes in total. Therefore, when you put your stethoscope on the patient's chest, you need to listen to the 5 lobes. On the right side, this is for the upper lobe, middle lobe, and lower lobe. For the left side, you only need upper lobe and lower lobe. This is the right lung. It has an upper lobe, it has a middle lobe, and it has a lower lobe. When you look at the anterior aspect of the lung, you only see the upper and the middle lobe. But when you look at the back of the lung, you see the upper, but mostly you see the lower. As for the left lung, it has only upper lobe and lower lobe. What happened to the middle lobe? The heart took its place because the apex of the heart leans to the left. And instead of having an entire middle lobe, you only have its substitute, the lingula. This is the chest wall or thoracic cavity or thoracic cage. This is the right lung, this is the left lung. What is this? This is the pleural space or pleural cavity. What bone is this? The sternum. How about these bones? These are the ribs. The ribs are bones, but the last part is a costal cartilage, not bone. Remember that your heart is a central organ, but the apex of the heart leans to the left in most people. And this is the cardiac notch, and that's why the left lung only has 2 lobes instead of 3. Here is the right lung, here is the left lung, and the heart sitting in the middle with the apex of the heart leaning left. Because the heart is liberal. For the gazillionth time, upper lobe, middle lobe, lower lobe, but on the left it's only upper and lower. Here is a tip for the pros. If you want to hear the 3 lobes on the right side and make sure that you do not miss anything, listen to the lungs under the patient's armpit. At that plane, which is the mid-axillary line, you can hear the upper lobe, the middle lobe, and the lower lobe, respectively. And on the left, you can hear the upper lobe and the lower lobe. For a more robust explanation, I have 2 videos for the anatomy of the thorax. Part 1 is called Quick Review, and Part 2 is called Ultimate Review. You can watch both videos in my anatomy playlist. What's the next topic? Signs of respiratory distress. These include tachypnea or bradypnea. The patient is sitting in the tripod position, meaning upright and leaning forwards with the upper half of the body. Difficulty talking, especially in complete sentences. The patient is very anxious. There probably is a skin tone change. Could be pallor, could be cyanosis. Cyan means blue, so cyanosis means bluish discoloration. Using pulse oximetry, there is decreased oxygen percent saturation and maybe delayed capillary refill time, which we have talked about before. It will be delayed more than 2 seconds, and that's not good. In neonates or infants, we have other additional symptoms of respiratory distress, including nasal flaring. The openings of the nose are very wide because the baby is struggling to breathe. Grunting, intercostal retractions. Between the ribs, you find the skin being pulled inwards, struggling to breathe, and cyanosis. Next, respiratory failure. The following can happen: hypoxia, meaning less oxygen in the body. Hypercapnia, meaning more carbon dioxide in the body. Don't forget that carbon dioxide is technically an acid or clinically an acid because it will combine with water and give you what? It will give you carbonic acid. And carbonic acid is, well, guess what? An acid. Duh. So if I have lots of acids, it's called acidosis. Osis means condition of acids. And that's why the name of my channel is Medicosis Perfectionalis. It's a condition of perfect medicine. Anytime the protons accumulate because I have too much acid, the pH will drop, and this is the acidosis. When I have low oxygen in the body, there will be less oxygen on the hemoglobin, so the SaO2 will decrease on pulse oximetry. We need to start ventilatory support for this patient. If we fail to do so, or if the patient deteriorates, complications include respiratory arrest, changing in skin color, could be gray, could be blue, could be white, and you need to start CPR. Next, respiratory examination. Inspection, palpation, percussion, auscultation. Inspection, palpation, percussion, auscultation. Inspection, what should I look at? Look at the patient's body position. Do we have a tripod position? Do we have any abnormal skin discoloration? Do we see any abdominal breathing? Abnormal. Paradoxical breathing of flail chest? Abnormal. Accessory muscle use, such as the muscles of the neck, including the sternocleidomastoid. This is a patient who's struggling to breathe. Palpation meaning touching with your hands. Touch the trachea, make sure it's central. It is supposed to be central, neither shifted to the left nor to the right. Put both of your hands at the level of the diaphragm and notice the patient's breathing. There should be equal expansion on the right side and on the left side. Unequal expansion is a disease. Make sure that the patient's lung expansion is symmetrical on both sides, not just that, but has enough volume in it. Remember that volume times rate equals ventilation. Tactile vocal fremitus can help you diagnose consolidation, such as pneumonia. Percussion is to tap. Tap, tap, tap. Where did we get percussion from? The legend has it that there was a medical student whose father owned a winery. And growing up, this kid was taught by his father, "Listen, my son, and you shall hear, and get your head out of your rear. If you want to know whether this barrel is filled with wine or not without opening it, in order to save time, because time is money, you simply need some percussion technique. What do? Well, you tap on the barrel with your fingers. If it's resonant, it means there is air behind your fingers. That's not wine. And then you keep descending and descending and descending until you hear dullness. Once there is shift in the percussion node from resonant to dull, this is where the fluid level is." This young lad took this knowledge to medical school and invented percussion as a medical examination technique. Normally, the lungs should be resonant because they have air. They should not be hyperresonant. That's abnormal. This means too much air. Why? Because I have tension pneumothorax. There is a hole in my chest wall, and this hole in the chest wall is allowing air into the pleural cavity, but not out, like a valve. What's the purpose of the valve in your car's tire? To let air in, but not out. This valve-like mechanism happens to the patient of tension pneumothorax, and air keeps piling up inside the pleural cavity. And of course, too much air will make the node hyperresonant. What is the opposite end of this? The opposite extreme is dull to percussion. Why? Because instead of air, I have fluid. But of course, the patient's pleural cavity will not be filled with wine. Even if your patient is a raging alcoholic, it will be filled with water. What do you mean by water? Plasma components shifting into the pleural cavity, or could be filled with blood. We call that hemothorax, or could be filled with lymph. We call that chylothorax. All of these will be dull to percussion. Then you get your doozy stethoscope and listen to the patient's chest. You need to auscultate both lungs, meaning 5 lobes in total. Then with pulse oximetry, you will know the SaO2 or the oxygen saturation or the percent saturation. Then you need to examine the patient's respiratory rate. This is part of the vital signs, the depth or the tidal volume, the rhythm of breathing, and the quality of breathing. Next, abnormal breath sounds. Now, every book has its own classification. Some use very archaic terms, but the new classification is very simple. You only have 3 abnormal breath sounds. It could be wheezing / stridor. It could be crackles, whether they are dry or wet, fine or coarse, we don't care. And friction rub. These are the 3 types of abnormal breath sounds. Wheezing and stridor are very musical in nature. What's the difference? Wheezing is coming from the lower airway, such as the bronchi, the bronchioles, etc. But stridor is coming from the upper airways, such as the larynx or the trachea. Next, crackles. Now, in the good old days, which were not so good, we had crackles, we had rales de la mort, which means rattles of death, and rhonchi, singular rhoncus. But now, it's easier to just lump them together as crackles and then divide the crackles into dry and wet. Wet crackles means water. Why is my lungs filling up with water? It could be because of a failure in the left side of the heart. Let's say that the left ventricle has failed. Where do you think the blood will go? The blood will pile up in the left atrium, and then it will back up and pile up in the lungs. And now the lungs will be filled with fluid. Fluid. Oh yeah, all of that is fluid. We call this wet crackles. And if it's caused by a problem in the left side of the heart, such as left-sided heart failure, we call them rales. Rales de la mort, rattles of death. Dry crackles, on the other hand, do not have water. They could be heard in many situations, including lung fibrosis. Last, the emergency situation of status asthmaticus. To learn more, I have a video called Bronchial Asthma in my pulmonology playlist. Remember that not all asthmas are created equal. There is intermittent, there is mild persistent, moderate persistent, and the worst, severe persistent. You need to know about these 2 special cases of asthma: exercise-induced asthma and status asthmaticus. Exercise-induced asthma, as the name suggests, when I exercise, I have spasms of my bronchi, and I have asthma, and I have wheezing. How should we manage this? With an inhaler containing what? Short-acting beta agonist, preferably before exercise. What if we did not catch the patient before the exercise and now the patient has an asthma attack? We give short-acting beta agonists such as albuterol and moist air. Moist and warm. The second scenario is status asthmaticus. This is a true medical emergency. We need to take the patient to the hospital. The treatment includes short-acting beta agonist. Give it once. Wait for 20 minutes. Give it again. What if it's worse than this? Then I'm going to give short-acting beta agonists such as albuterol plus oxygen plus oral corticosteroids. What if it's more severe than this? Short-acting beta agonist plus ipratropium. What if there is respiratory failure? We need to intubate in the ICU. Now, what do we expect when the patient has asthma? During the asthma attack, the patient should be hyperventilating. This is what we expect. However, what if we found the opposite? What if we have a patient with asthma who is hypoventilating? That's a huge red flag, because when I breathe less, carbon dioxide accumulates in my body. This is hypercapnia. And hypercapnia could be a sign of respiratory failure, whether it's already here or coming very soon. Another important tip for asthma patients during ventilation: do not ventilate them too rapidly. Because asthma is an obstructive lung disease. The definition of obstructive lung disease is that I cannot get the air out, which means that I need time to exhale and empty my lungs. If you ventilate me too quickly, you are taking away my time, making it very difficult for me to push the air out. Carbon dioxide piles in, I get hypercapnia, and we're back to the same disaster. So do not ventilate your asthma patient too quickly. Allow for a little bit of permissive hypercapnia, and you should aim at an SaO2 or oxygen saturation of 90% or higher. The treatment of asthma is based on the severity of asthma. What is cardiac asthma? Oh, this is an asthma, but blame the heart for this asthma. It's caused by a cardiac problem, such as left-sided heart failure. Because when the left side of the heart is not contracting, what's going to happen? Blood will pile up in the left atrium, and then in the pulmonary veins, and then in the lungs. So the lungs will be filled with fluid, and I will start to cough and cough and cough, and this is cardiac asthma. In the next video, we shall talk about airway management. It's a very important topic. You do not want to miss it. Let's answer the question of the previous video. Which of the following respiratory rates in a neonate is concerning for difficulty breathing? Is it A, 40 breaths per minute, 45, 50, 55, 60, or 70? First, what's the normal? Well, the normal respiratory rate in a neonate is between 40 and 60. This is what we expect. 70, however, is not what we expect. 70 is too high. 70 is hyperventilating. 70 is abnormal. Therefore, 70 is the correct answer. And here is today's question. In order to choose an oropharyngeal airway, its size should match or be roughly equal to the distance between blank and blank. Is it the tip of the chin and the forehead? Is it the tip of the nose and the nipple? Right nipple or left nipple, I don't care. Right eye to the left eye, between the corner of the mouth and the tip of the earlobe, between the corner of the mouth and the tip of the nose, or between the tip of the chin and the tip of the nose. Pause the video, let me know your answer in the comments. You will find the answer key in an upcoming video in this EMS playlist. Do you want to learn about cardiac arrhythmias, myocardial infarction, stroke, acute respiratory distress syndrome, acute limb ischemia, drowning, all the toxic syndromes that you can imagine and their antidotes? Download my emergency medicine high yields course at medicosisperfectionalis.com. It comes with videos, notes, and cases. If you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.